Idiopathic retroperitoneal fibrosis. Idiopathic retroperitoneal fibrosis, IRF, also known as Ormond's disease, is a rare chronic inflammatory condition characterized by the development of fibrous tissue in the retroperitoneal space. This fibrous tissue can encase nearby structures, most commonly the ureters, leading to ureteral obstruction, kidney damage, and other complications. The term idiopathic implies that the condition arises spontaneously or for reasons that are not well understood. Pathophysiology. IRF is believed to result from an excessive autoimmune or inflammatory response. The inflammation leads to the deposition of fibroconnective tissue in the retroperitoneum, often centered around the abdominal aorta and iliac vessels. It may involve other organs or structures, including the ureters, kidneys, and sometimes the inferior vena cava or bowel. Etiology. Although the exact cause of IRF is unknown, several factors have been implicated. 1. Idiopathic, primary, no identifiable cause, often associated with autoimmune or systemic inflammatory disorders, e.g. IgG4-related disease. 2. Secondary causes, chronic infections, e.g. tuberculosis, syphilis, actinomycosis, drug-induced, e.g. ergot derivatives, methosergide, beta blockers. Malignancies, e.g. lymphoma, sarcoma, or metastatic cancers. Trauma or surgery. Clinical presentation. The symptoms of IRF vary depending on the extent and location of the fibrous tissue. Common features include 1. General symptoms, fatigue, weight loss, low-grade fever. 2. Local symptoms, dull, nonspecific abdominal or flank pain, back pain. 3. Complications, ureteral obstruction leading to hydronephrosis or kidney failure, lower limb edema due to compression of veins or lymphatics, hypertension secondary to renal artery involvement, constipation or bowel obstruction in severe cases. Diagnosis. 1. Clinical history and examination, persistent abdominal or flank pain, symptoms of urinary obstruction. 2. Laboratory tests, elevated inflammatory markers, e.g. ESR-CRP, renal function tests to assess kidney damage, autoimmune markers, e.g. ANA, IgG4 levels. 3. Imaging studies, CT scan, preferred, identifies a retroperitoneal mass encasing the aorta and ureters. MRI differentiates fibrosis from malignancy or other pathologies. Ultrasound detects hydronephrosis, helps assess active inflammation and exclude malignancy. 4. Biopsy, if needed, performed to rule out malignancy or other secondary causes. Management. The treatment of IRF aims to reduce inflammation, halt fibrotic progression, and relieve complications like ureteral obstruction. 1. Medical therapy. Corticosteroids, first-line treatment, e.g. prednisone, reduces inflammation and fibrosis. Immunosuppressive agents, methotrexate, azathioprine, or mycophenolate mofetil in steroid-resistant cases. Biologic agents, rituximab for cases linked to IgG4-related disease. 2. Surgical management. For cases with significant ureteral obstruction, ureterolysis, surgical release of encased ureters, ureteral stenting or percutaneous nephrostomy to relieve obstruction. 3. Treatment of secondary causes. Discontinue causative drugs. Treat underlying infections or malignancies. Prognosis. With early diagnosis and appropriate treatment, IRF often responds well, especially if managed with corticosteroids. Delayed diagnosis or untreated IRF can lead to irreversible kidney damage or severe complications. Recurrence is possible, and long-term follow-up is necessary. Differential diagnosis, malignancies, e.g. retroperitoneal lymphoma, sarcoma, infectious diseases, e.g. tuberculosis, actinomycosis, other fibrotic diseases, e.g. sclerosing mesenteritis, mediastinal fibrosis. Conclusion. Idiopathic retroperitoneal fibrosis is a rare but treatable condition that requires a multidisciplinary approach for diagnosis and management. Early recognition and intervention are crucial to preventing irreversible complications, particularly renal failure.